بسم الله الرحمن الرحيم. المحاضرة اليوم إن شاء الله على الإبيليبسي أبديت. في بداية المحاضرة بحب أتوجه بالشكر لرابطة أطباء الأطفال بدمياط. أتوجه بالشكر للأستاذ الدكتور باسم شمس على دعوته الكريمة وباقي القائمين على هذا العمل الجليل. وكنت طبعا أتمنى أكون موجود في المؤتمر السابق للرابطة، لكن يعني ظروف سفر حالت دون وجودي. وطبعا السيشن كان على قدر كبير من التميز وبرئاسة الدكتور أحمد رؤوف. فطبعا إن شاء الله نبقى معاكم في المرات القادمة. النهاردة هنتكلم على الشايلدهود إبيليبسي والنيو definitions of the International League Against Epilepsy. To start with, we will deal with the definitions, the new definitions of seizure, epilepsy, convulsion, and these terms has to be defined appropriately in order to reach appropriate diagnosis. طبعا considering in epilepsy in children is becoming of higher incidence than before, so it is appropriate to define the terminology of the International League Against Epilepsy to help us in proper diagnosis. So what is the difference between seizure, epilepsy, convulsion, fit, and all these terms that's used in pediatric neurology? The broad term of this nomenclature is the fit. A fit is not necessarily to be a seizure. The fit could be a faint, could be a breath holding spell, it could be a non-paroxysmal event, non-paroxysmal non-epileptic disorder. So the fit could be anything, not only a seizure. A seizure is a fit, but not all fits are seizures. So what is a seizure? A seizure is an event that happens in the neurons of the brain where either synchronous discharge of the neurons of the brain or abnormal excessive neuronal hyperexcitability. So either there is synchronized discharge of a great population of neurons, or there is hyperexcitability or excessive discharge of these population of neurons. This will lead to a clinical and electric event. The clinical event could be motor event, sensory event, autonomic event, or psychic event. So the seizure could be one of these four categories. The seizures, when we classify the seizures in the past, we were saying that there is partial seizure and generalized seizure. But now the new terms will be focal and generalized seizures. The term partial is replaced by the term focal, in which the electric discharge is originating from one cerebral hemisphere. Generalized seizure means that the electric discharge is originating from both cerebral hemispheres, and this will be reflected on the clinical picture of the seizure. Further classification will put dichotomies of simple partial or simple focal seizure and complex focal seizure. Again, the terms simple versus complex are old terms, and the new classification is either a focal seizure with preserved level of consciousness or preserved level of awareness, and a focal seizure with disturbed level of awareness, and it's called focal dyscognitive seizure. Then the generalized seizure classification, either it is a motor seizure, and the motor seizure could be a clonic, tonic, tonic-clonic, atonic, myoclonic, or epileptic spasm. To start with the clonic, clonic means there is contraction of the muscles followed by relaxation, and the relaxation is usually more than 50 milliseconds. In myoclonic, there is shock-like contractions of the muscles. Okay. So the tonic-clonic starts with the tonic phase followed by the clonic phase. The atonic means that there is loss of the muscle tone resulting in fall attack, and this drop attack could be with part of the body, like head drop to the backwards or forwards, or complete loss of body tone and dropping to the ground. Last one is the epileptic spasms. Epileptic spasms somewhat or sometimes are classified as generalized, and in the new classification it is put in a separate entity as epileptic spasms. The epileptic spasms means that there is axial contraction or contraction of the axial muscles, and this could result in extension type, in which there is extension of the neck extensors or contraction of the neck extensors and the paraspinal muscles, resulting in falling backwards, or flexion spasms, in which there is contraction of the neck flexors and there is also adduction and flexion. Sorry. And this is a flexion type, and there is also a mixed type in which there is flexion and extension. After the we resumed now the connection. I was saying that the epilepsy is different from the seizures. The seizures could be an acute symptomatic seizure due to an acute event insulting the brain, like trauma, like head trauma, like infectious process in the central nervous system, like toxin, and so on. This process will result in a synchronous discharge of a population of the neurons, or hyperexcitability of and excessive discharge of this population of neurons, resulting in a seizure. Acute symptomatic seizures are not epilepsy because it is almost always synchronized, temporally synchronized or timely synchronized with the event that insulted the brain. Like a child having seizures in the setting of meningitis, in the course of meningitis. So after meningitis, the seizures will not come again. Or post-traumatic seizures, early post-traumatic seizures. These seizures will occur during brain trauma and will not come again, and so on. These are called acute symptomatic seizures. They are not epilepsy. Again, febrile seizures. Febrile seizures are seizures in the event of infectious process outside the central nervous system, resulting in hyperexcitability of the neurons and seizures. It is linked to specific age of the infant, and this is not epilepsy. Some reflex or startle seizures are not epileptic because it is linked to an acute event. Also, if a seizure occurred without provocation, and repeated within 24 hours, we call this epilepsy. So the epilepsy means that we have 2 unprovoked seizures more than 24 hours apart. Is there an exception for this definition? Yes. Do we might have 1 seizure unprovoked and we call it epilepsy? Yes. If the EEG is conclusive of an epileptic syndrome, we can say after the first unprovoked seizure that this is epilepsy. For example, in absent seizure, the child have stirring spell, and we do an EEG. We find the 3 cycles per second discharge. So this is absence epilepsy. I will not wait for another setting or visit for diagnosis. Again, infantile spasm. If I captured an infant having this epileptic spasm, flexion type or extension type, and it was coming in serious and clustering, I mean like 15 to 20 times per cluster, and these clusters are repeated during the day many times. So this is a clinical event that goes with infantile spasm. So I can label the infant as having epilepsy from the first visit. So one unprovoked seizure plus conclusive EEG and clinical picture can diagnose epilepsy, or 2 unprovoked seizures more than 24 hours apart. So the epilepsy, etiological profile of epilepsy. In the past, we were calling those epileptics without a cause, with meticulous history taking and meticulous investigations, and of course clinical exam. If we didn't find any positive findings, we call this epilepsy of unknown cause. That was called in the past as idiopathic epilepsy. Now it is called genetic epilepsy or presumed genetic epilepsy. If there is a cause of epilepsy, like brain malformation, gliosis, cortical dysplasia, porencephaly, mesial temporal sclerosis, all of these are organic causes of epilepsy that could occur post-traumatic, prenatal, post-infectious, and so on. If there is a cause, we call this symptomatic epilepsy, and this term also have changed to structural metabolic epilepsy. So that the 2 new terms now are structural metabolic epilepsy instead of symptomatic epilepsy, and genetic epilepsy instead of idiopathic epilepsy. In between these 2 categories, there is the cryptogenic epilepsy. That is epilepsy with a probable cause that will appear later on. But why I say this is cryptogenic? If the infant is having epilepsy, or the child having epilepsy, and this epilepsy is not benign in terms of developmental regression, we cannot label this as idiopathic. We label this as an epileptic condition with a cause that might appear later on. So we called this in the past as cryptogenic epilepsy. But now it's called unknown epilepsy, or epilepsy of unknown cause. So now these are the 3 categories etiological categories of epilepsy. Instead of idiopathic, genetic epilepsy, structural metabolic, or unknown epilepsy. Now we come to the difference between an epileptic disorder and epileptic syndrome. Epileptic syndrome is an entity gathering or constituting a different items. First, an age group. If we define a certain age group for the epileptic disorder, like the benign childhood epilepsy with centrotemporal spikes, starts at the age around 3 years and relieved at or cured at the age of 16 years. So this is an specific age group for benign Rolandic epilepsy. If it is benign in terms of normal neurological profile, neurological examination is normal, developmental history is normal. After the onset of seizures, there is no developmental regression. There is no school underachievement. Also, the EEG is specific with the centrotemporal spikes. The neuroimaging profile constitutes or goes with idiopathic or genetic form of epilepsy. There is no organic cause. So if we put the age group plus neurological examination plus developmental profile plus EEG plus neuroimaging, and last one, which is the most important one, prognosis, which is good benign prognosis in terms of control with one drug, self-remission at certain age, no affection of cognitive function. All of these constitute a syndrome. So the epileptic syndrome gathers all of these criteria. Last category is epileptic encephalopathy. What is the difference between an epileptic encephalopathy and epileptic disorder? If a child or infant has epilepsy and there is developmental regression or cognitive regression, and this cognitive regression is explained only by the epilepsy and not other causes, we call this epileptic encephalopathy. For example, the early infantile epileptic encephalopathy or the Ohtahara syndrome that starts at the age of 3 months, in which there is a burst suppression pattern in the EEG. With the onset of the burst suppression pattern, there is developmental disachievement or regression, or there is no achievement of the normal developmental milestones. The early myoclonic encephalopathy, also with the burst suppression pattern, the same. Landau-Kleffner. Also, there is acquired epileptic aphasia. There is specific the continuous spike slow waves during slow sleep. All of these epileptic pattern are consistent with specific severe EEG abnormal discharges, and these discharges are the cause of the developmental regression. Okay, after that I'll go to the diagnosis of epilepsy in infants and children. Proper evaluation of epilepsy will need appropriate classification first of epileptic seizure and syndrome. I would like to say that generalized epilepsy syndromes may be difficult to identify at onset because they start with partial seizures. For example, we have a syndrome of severe myoclonic epilepsy or in infancy. This syndrome is a generalized epileptic syndrome, but it could start with hemiclonic seizures, febrile hemiclonic seizures. So the onset of the seizure may constitute a difficulty to diagnose focal versus generalized epilepsy. Again, the evolution of the syndromes. For example, we have the Ohtahara syndrome, the early infantile epileptic encephalopathy. It can evolve to West syndrome, which is symptomatic infantile spasm. And this will evolve to Lennox-Gastaut syndrome. So the evolution of epileptic syndrome also constitutes another diagnostic difficulty. The last diagnostic difficulty is the pseudo-seizures. We have to rule out that there is a psychogenic simulation of a seizure disorder. Usually this occurs in adolescence, and there is a template for epilepsy in the family, whether the patient himself after being cured or another family member with epilepsy. And usually these seizures are bizarre shaped. They are not causing harm or injury, and they are not accompanied with autonomic manifestation like stool incontinence or urinary incontinence, and the EEG, of course, is unremarkable. So, to start with the appropriate diagnosis of an infant with epilepsy, we have to have adequate history taking. The initial phase of the seizure, as I have mentioned, is important for localization of an epileptic focus. For example, in frontal lobe seizures, we have what's called the figure of four semiology. What is the figure of four? There is dystonic posturing of one upper limb with flexion of one of the other upper limb, giving the figure of four pattern like this. So the initial phase of the seizure could be helpful in localizing the origin of the epileptic focus. Again, from the history, we can elicit if there is preceding a febrile illness to rule out febrile seizures, or the epileptic syndromes that follow febrile seizures, like Rolandic epilepsy could follow febrile seizures due to mesial temporal sclerosis. Again, there is ADEM, acute disseminated encephalomyelitis. This is a symptomatic type of epilepsy that follow febrile seizure. Also, Dravet syndrome, severe myoclonic epilepsy of infancy. This follows febrile seizure. So, if there is a fever preceding the seizure, this is very important in diagnosing the epilepsy. Also, rule out head trauma, rule out intoxication, anything to rule out the acute symptomatic seizures. After that, we go to the examination. We have to examine if there is signs of localization. Hemiparesis will point to some structural abnormality in the brain, like porencephaly, like encephalomalacia at one side, cortical dysplasia. Scheme manifestations will point to neurocutaneous epileptic syndromes like tuberous sclerosis, where there is ash leaf macules, there is chagrin patch, retinal phacomas, also the neurofibromatosis, where the cafe au lait patches, Sturge-Weber, will find the V1 and V2 abnormal hamartomas, and so on. So the neurological examination could define a certain cause for the epileptic disorder, whether it is an acute symptomatic seizures versus an epileptic syndrome. Then the EEG. The EEG is, of course, is indicated. Now the famous question whether to do the EEG immediately after a seizure, or to postpone the EEG for after 3 weeks or 2 weeks. If we are in a diagnostic dilemma of ruling out an epileptic syndrome, it is important to do an early EEG to rule out specific epileptic disorder like infantile spasm, absence seizure, Rolandic epilepsy, Landau-Kleffner. All of these have specific EEG patterns. But if we are in a clinical scenario consistent with febrile convulsions, what is the yield of an early EEG? It will show post-ictal phenomena. So if the neurological profile is normal, developmental profile is normal, neurological examination is okay, no need to do an immediate EEG with a scenario like febrile convulsion, and we have to postpone it after 3 weeks to get rid of this post-ictal slowing that may mask any abnormal electric discharge. I would like to see the duration. Okay. Then what are the indications of neuroimaging to diagnose epilepsy? If we have abnormal neurological exam, especially with a focal neurological signs, if we have abnormal developmental profile of the infant or the child, if the age of the infant is less than 1 year, all these are indications to have a neuroimaging. And the best neuroimaging tool for diagnosis is an MRI versus CT. MRI is better to be done with the T2 and the FLAIR images. And if we are suspecting a metabolic versus infectious process, diffusion weighted images are also helpful. Of course, functional neuroimaging techniques in suspected cases of a metabolic disorder could increase the diagnostic yield. So we have to exclude pseudo seizures, to classify seizure type, to determine seizure frequency, and to classify epileptic syndrome in order to reach a proper diagnosis. What are the goals of therapy in epilepsy? Our ideal goal is to abort the seizures completely, eliminate the seizures. But in some cases, my aim is to reduce the seizure where there is intractable epileptic condition like Lennox-Gastaut, Dravet syndrome. My aim will be is to give the patient a better quality of life with reduction of the seizure frequency. The second aim is to reduce the risks of the adverse events of the seizure medication and to balance the risk of therapy with the benefits of being in a seizure-free period. And lastly, to improve the patient's quality of life. This is the goals.